Good evening to one and all. Thank you for joining today's session, which is a very important session that we've been planning for quite some time on a topic which I think is something that we all talk about on a daily basis. We talk about why children need to sleep, why is sleep so essential for health, right? But many a times, even when we go out and talk to other CMEs, talk to other doctors as well, many times we fumble to give exact evidence as to why children really need to sleep. It sounds like a very generic topic, right? It sounds like a very generic statement. Of course, we all need to sleep, but where is the evidence for that? What are the specific points that we need to talk about when we say children need to sleep? So in celebration of this World Sleep Month, rather, I would say, where we knew that we all celebrated World Sleep Day on March 17, 2023, the topic or the theme chosen for 2023 has been that sleep is essential for health. So it is very apt for us to have our guest speaker, Dr. Maya Ramagopal, who is a reputed person in pediatric sleep medicine, but has also been visiting many of our Indian conferences as well, to speak on this important topic. I mean, of course, Dr. Maya is a very good friend of mine. I end up happily meeting her every time she's back in Bangalore to visit her family. But Dr. Maya is also somebody who's extremely accomplished in the pediatric sleep world. She completed an MBBS and MD degree from the Jawaharlal Institute of Postgraduate Medical Education, JIPMER in Pondicherry. And since she's gone to the United States, she completed her pediatric residency at Fletcher Allen Healthcare, University of Vermont in Burlington, Vermont, and earned her fellowship in pediatric pulmonary medicine at Montreal Children's Hospital in Canada. Dr. Ramagopal is a board-certified pediatric pulmonologist with additional specialization in sleep medicine. In addition to serving patients at the Bristol Myers Squibb Children's Hospital at Robert Wood Johnson University Hospital, she's an associate professor at Rutgers Robert Wood Johnson Medical School as well. Dr. Maya works extensively in the field of pediatric asthma, pediatric sleep medicine, pulmonary function testing in preschool age group, bronchopulmonary dysplasia, flexible bronchoscopies, and transbronchial biopsies. But of course, Dr. Maya has been involved with also our diploma in pediatric sleep medicine program. She has delivered talks, conducted some of our journal clubs as well. So we're very glad to have Dr. Maya here talk to us about an important topic on why sleep is essential for children. What is the different topics that we talk about when we talk about sleep being important for children? And over to you, Dr. Maya. And welcome to you once again to speak to an Indian audience today on why sleep is so important for us.
Thank you so much, Dr. Bharath. And okay, you can see this, right?
Yeah, we are able to see your slides. Please go ahead.
Okay. All right, thank you so much for inviting me to talk to all of you today. I am actually very impressed with how Dr. Bharath has put this all together and giving you all to have an opportunity to learn more about sleep medicine, and also, us to be able to participate in this. And it's such an important topic, as you obviously already know. Okay, why is this not? Here we go.
Now it's
okay. We just talked a lot about World Sleep Day, and Dr. Bharath has actually called it World Sleep Month, which I think is probably more appropriate. And you all know by now that the theme for this year was sleep essential for health. So when I was, thinking about what I should put into this topic, I thought I should address a couple of things. And like Dr. Bharath already said, we kind of take sleep for granted. Yeah, everyone needs to sleep, but really it's really not such a simple process, as you already know. So why really do children and all of us actually need to sleep? I also want to address the reasons for poor sleep in children and what can we do about it once we realize that the children's sleep is really not optimal. And what is this sleep hygiene thing that we all talk about? So you are all probably very familiar with this slide, and this is something that the National Sleep Foundation has put out, and about the sleep duration recommendations for various age groups. So we know that the sleep need actually decreases as we get older. So it's the highest in the newborn period and gradually comes down to in the teenage years, young adults, and of course, older adults need the least amount of sleep. So how this graph should be interpreted is as follows. The dark blue bar is what the recommended duration of sleep is for the respective ages. The light blue on either side is what we call maybe appropriate, but anything in the yellow zone is really not recommended. So you don't want somebody to get too little sleep and also too much sleep. So with that in mind, I'm sorry about that. The Sleep in America poll is something that the National Sleep Foundation conducts periodically. This is a self-reported questionnaire where they ask people about all sorts of questions about sleep. And this self-reported sleep duration is data that they collected. So when 11-year-olds were asked how much sleep they actually get per night, the response was 8.4 hours of sleep a night, when the recommendation is closer to 9.5, 10. 14-year-olds, for example, should be getting about 8 to 9 hours of sleep. They reported that they only get about 7.6. And the teenagers, who are notoriously poor sleepers, got only 6.9 hours of sleep, and they should actually be getting at least 8 hours of sleep. So we all know that sleep deprivation and insufficient sleep is sort of a global phenomenon now, and we have the proof for that. So like I said, this sleep is really not a quiet period of time. Okay, we are quiet, sort of dead to the world, but there's a lot of things that actually go on in our bodies. I just want to touch on a couple of things that are relevant to this. And I would start with the interplay of the endocrine system with sleep and circadian rhythms. This is like a topic in and of itself, but I just want to sort of touch on some of the highlights of it. So we all know about the SCN, which is a suprachiasmatic nucleus, which sits in the anterior hypothalamus. And it is what we consider the master pacemaker, the master clock. And that is regulated by the light that we see. And the light travels via the retinal hypothalamic tract, the ganglion cells, and it takes care of the light and dark cycles in our body. In addition to this master pacemaker, there are also peripheral pacemakers in all the tissues of the body. Of relevance here is the pacemakers in the stomach, in the liver, because that definitely affects how, and they all have their own circadian rhythms, and any sort of mess up of that can interfere with sleep as well. So what does this SCN do? It stimulates the adrenal cortex by the HPA, which is the hypothalamic pituitary axis. The melatonin also plays a role. And what I'm really getting at is how the glucocorticoid synthesis and stimulation occurs. This in turn, and then the food intake that we have is sort of another big factor that plays into this. So once we eat food via insulin and the oxyntomodulin and metabolites like glucose and fatty acids also stimulate the adrenal cortex to bring out various hormonal secretions. The stomach is responsible for secreting ghrelin, and the ghrelin is a hormone that responds to hunger. The food also has a negative sort of inverse relationship with leptin, which is secreted by the adipose tissues. The liver, once the food, it senses food intake, is responsible also for gluconeogenesis, and via the fibroblastic growth factor, stimulates or increases the systemic glucocorticoid steroids. So basically all this to say that, this cycle is also very tightly regulated in the body during sleep. And any imbalance to this tight cycle is also going to impact the sleep. And we are kind of notorious for this happening with our modern lifestyle. We don't really follow sort of circadian rhythm rules for when we eat and when we sleep. So I think the take home from this should just be that there's a complex interaction of the hormonal balance in our body and sleep and the food intake times. The other hormone that's very responsible for sleep, or is very tied into the timing of sleep, is melatonin secretion. So on this graph, I just wanted to show you on the y-axis is the concentration of melatonin in picograms per ml. And on the x-axis is the time of day. So melatonin production starts about in the evening, when this is why it's called the hormone of darkness. It starts to sort of go up as nightfall happens. The levels peak in the middle of the night, and it starts to come down towards the early morning, and it's really low when it's wake up time around, in this particular instance, at 7 a.m. This circadian clock is also excruciatingly sensitive to light. And it's extremely, in general, it's very sensitive to light, but it is very sensitive about 2 hours before bedtime. It's also pretty sensitive throughout the night and 1 hour before usual bedtime. So any light exposure in these times is also going to affect the quality and the duration of sleep. The other hormones of interest in children with sleep is the growth hormone and cortisol secretion. So if you look at this right-hand side, right hand for me, it's a hypnogram in a child. So if this would be sort of reflective of the whole in a sleep study. So basically, we go into sleep in non-REM sleep, and the REM cycles, which in this graph are represented by the dark red bars, those represent REM sleep. So REM, as you know, cycles about every 90 minutes, and the duration gets longer and longer as sleep carries on through the night. So the deep sleep, which is N3, slow wave sleep, occurs in the early part of the night, where growth hormone secretion is the highest. The cortisol secretion actually starts to go up towards the latter part of the night and of sleep, and it is the highest when you wake up in the morning. So again, and then cortisol is very dependent on the circadian rhythm. Growth hormone is actually not, it's just sleep stages. So even if somebody sleeps in the middle of the afternoon, gets into N3 sleep, you will still get growth hormone secretion, but not so with cortisol. So again, just keep this in mind as we go along the talk. So this is something pretty familiar, I'm sure, to all of you. So these are children who are clearly, in school, in some kind of activities they should be engaging in, and they are falling asleep. So what could possibly be the reasons for this to happen? I just put this up here for an idea of all the kinds of sleep problems that can occur at the different age groups. And we are really concerned about sort of the chronic problems of sleep, which can arise at different age groups. So young infants can also get sleep apnea. You can have, there's mostly sort of behavior problems in toddlers for sleep, poor sleep, but they can also get other problems. So it sort of varies between the ages. And keep in mind that once we get into the school age and the teenage years, insufficient sleep becomes a bigger issue. So again, just to go through the list of poor sleep in children, I just divided it into medical and non-medical. The medical, you all know from the previous slide: sleep disordered breathing, parasomnias, movement disorders, central hypersomnia such as narcolepsy or idiopathic hypersomnia, circadian rhythm problems, which in children is mostly delayed phase sleep disorders, and anxiety and depression are all causes of poor sleep. There are non-medical problems also that we should keep in mind. As behavioral insomnia is typically seen, it can be seen at any age, but it's mostly seen in the younger children. Insufficient sleep is a huge problem. Now it's becoming a problem even in younger children. Also to be kept in mind is the environmental determinants that could affect sleep. There are physical factors such as noise, there's ambient light, air pollution. There's more and more literature now coming out that air pollution is responsible for sleep disordered breathing and therefore poor sleep. There are communities in the world, unfortunately, that children are exposed to that are, rife with crime and violence. Over here, it is the inner cities and also like places like refugee camps where definitely just physical factors affect the child's sleep. Also to be kept in mind is drug and alcohol use, which could be affecting sleep. So what are the signs of sleep deprivation? When you see children with behavior problems, temper tantrums, defiant behavior, the parent complains of difficulty waking up in the morning, difficulty with schoolwork, excessively long naps. So if you see a child typically over the age of 5 that is still napping during the day, your antenna should be going up and saying, what is happening at night? Why is this child really needing to still nap during the day when typically naps are really not necessary at this age at all? If this is a hyperactive child, a lot of times we get patients from the ADHD clinics, the neurologists refer these patients because they think they have ADHD symptoms, but really it is a sleep-related problem. Parents will complain of difficulty falling asleep because they are overtired. There can be an increase in appetite, as you saw in a couple of slides ago. If a child falls asleep right immediately, also suspect that there may be a sleep-related problem, or if they're accident-prone or clumsy. In older children, again, it could be daytime sleepiness, taking naps, hyperactivity, lack of focus in school. If you have a child who's been performing pretty well at school and suddenly the grades drop, think that this might be a sleep-related problem. Having emotional outbursts, difficulty getting up in the morning and being groggy upon waking up, and that grogginess sort of persists into the morning, then again, that should be a red flag. So this, it seems, is sort of taking over the world right now. This is a global phenomenon, and people are recognizing this to be the case. So I think these scenes are familiar to all of us. So there is actually quite a lot of literature on how extensive this problem is, including from the Pew Research Center. And they reported that 36% of children less than a year of age have interacted with a mobile device. 95% of teens have access to a smartphone. And 45% of them say that they are online almost all the time that they are awake. And this is including when they are in school. Lin Lee et al. In the Infant Behavior Development Journal published that excessive screen time in less than 5-year-olds was seen in 10 to 93% in high-income countries. Middle-income countries were actually more, 21 to 98%. So this is clearly a problem that the world is grappling with. So what did we do about this? The American Academy of Pediatrics came up with some recommendations. Initially in 2016, they reaffirmed this last year in 2022. And they said that for children less than 18 months of age, they strongly discourage the use of screen media other than video chatting. For children 18 to 24 months, they recommended choosing high quality programming and not to let the toddler use the phone by themselves, and there should be parental involvement. For children over 2, they limit media to less than an hour a day. And again, strongly recommended the shared use between parent and child to promote enhanced learning, greater interaction, and limit setting. They continued to say there was no screen should be allowed during meal times and 1 hour before bedtime. Avoid media as the only way to calm a child, except during stressful situations such as medical procedures. They said, of course, there are other situations where we would consider it stressful. Anyway, what they were trying to say is just don't, every time the child cries, don't say, here's the phone, just sort of entertain yourself, which is, which happens a lot, I think. They also recommended removing the devices from the bedroom before bedtime. And this is key. It's important for parents to not use their own devices during these times. I see this in my clinic all the time. So every time I give them the lecture about, no electronics in the bedroom, et cetera, the child always turns to the parent and says, how come you get to use the phone in bed and you're telling me not to use the phone? You see? So it's a problem on both fronts. Anyway, this publication the AAP called The Media and Young Minds, which I thought was very good. So what about for adolescents? So again, they said, please place consistent limits on screen time, promote the daily amount of physical exercise for at least an hour, and promote the age-appropriate amount of sleep. They recommended that children do not sleep with the device in their bedroom, avoid exposure to the screens at least 1 hour prior to bedtime, strongly discouraged entertainment media while doing homework, and they recommended designated media-free times, such as during a family dinner, and media-free locations in the home. This study was actually published in, it's a study from Ghaziabad, which was a 1 year in 2018. So this is all pre-COVID, because COVID, of course, threw everything off balance. But I thought this was, relevant because this was before COVID happened. So these investigators studied 100 subjects between 6 months and 2 years, of which there were majority male. They divided them into two groups. Group 1 had 25 subjects and they had no electronic gadget exposure. Group 2, and they were the controls. Group 2 were the subjects, and they were exposed to electronic gadgets for 4 to 5 hours a day. They followed these patients every 2 months for a year. And at the end of the 1 year period, they found that 18 subjects out of the 75 in group 2 showed cognitive delays. However, the motor milestones, however, were normal. The control group had normal developmental milestones, both cognitive and motor. And the most concerning part was these patients were very irritable when they would try to take the gadgets off and try to wean them. So again, they described this as a very hard thing to break. The Indian Academy of Pediatrics also has a set of guidelines on screen time and digital wellness in children, and which was recently published in Indian Pediatrics in 22. So they said pretty much the same things. They said less than 2 years, of course, they were a little more strict, I guess, no screen time at all. Between 2 and less than 5, they said 1 hour of supervised screen time, and 5 to 10, less than 2 hours of screen time a day. Over 10 years, they really had no time recommendations, but they did emphasize very strongly that screen time should not take the place of outdoor physical activity and sleep, which was actually good because, the AAP didn't really talk too much about sleep, but the IAP strongly emphasized that. And shouldn't also take the place of family and peer interactions, studies, and skill development. Families should ensure a warm, nurturing, supportive, fun-filled, secure home environment. The families, schools, pediatricians should be educated regarding the importance of tracking screen exposure and making digital wellness a part of routine child health assessment. And they also recommended, and actually I think this is a very good recommendation, to use this as an opportunity to detect early cyberbullying and media addiction. So another sort of buzz term in all of this is metabolic syndrome. So we are familiar with metabolic syndrome in the adults. It's only recently sort of making its way into pediatric literature, and it's mostly from the GI clinics that are treating a lot of patients with obesity, recommending them for bariatric surgery, etc. So what is metabolic syndrome exactly? So it's a cluster of metabolic disorders that encompass central obesity, also has impaired fasting glucose and dyslipidemia, which means increased triglycerides, decreased HDL cholesterol, hypertension, and increasing the risk of type 2 diabetes. The underlying pathology includes insulin resistance, and or the inflammatory state which accompanies obesity. And like I said before, the data is not as prolific in children as it is in adults. And this is because there is really not an accepted definition of metabolic syndrome in children as of yet. But this systematic review in 2021 put the prevalence of metabolic syndrome in children between 0.3 and 26%, depending on where the cohorts came from. So it is becoming a huge problem, even in pediatrics. So what about, we are interested in the sleep, and of course, sleep and metabolic syndrome are tied in because of all the other factors as well. So what do we know so far about this? The data on the sleep duration and dyslipidemia are conflicting, actually, in pediatrics. There are some papers that said sleep duration is directly related to HDL. Sleep duration is inversely related to elevated cholesterol and high LDL levels. And this survey from the Canadian Health Measures between 2007 and 2009 actually found no significant relationship between sleep quality and metabolic syndrome, even after they corrected for the BMI. That being said, this paper from Diabetes, Obesity, Metabolism said insufficient sleep is associated with insulin resistance in obese patients, but not in normal weight children. This paper said poor sleep quality is associated with poor sleep quality is associated with elevated blood pressure, and this was primarily due to blunting of the nocturnal dip. So we all know that this is very important actually in sleep apnea. Once we start to see that the nocturnal dip is lost, then it's becoming a problem. So we, leptin and ghrelin are sort of the key players in eating. So what is leptin and ghrelin are actually keep a fine balance with each other. So ghrelin is the hormone that's produced by the stomach, actually, and it is secreted in response to hunger. And leptin is secreted by the adipose tissues, and it is the satiety hormone. So before eating, ghrelin, because it's the hunger hormone, is elevated. And once eating is done, the ghrelin levels drop, and the leptin, because it's a satiety hormone, it is elevated. The reverse happens in sleep deprivation. So the ghrelin levels, which is the hunger hormone, levels go up, and the satiety hormones go down. So this is thought to be the basis of why obesity happens in sleep deprivation, because the hormonal levels are different, are changing. So no talk about this will be complete without actually talking about how big a problem of obesity in pediatrics actually is. So the CDC put out data, again, I used data which was before COVID. What they said was, and basically the definition of BMI in pediatrics is greater than the 95th percentile for children of the same age and gender. We don't use fixed numbers really for pediatrics, it's the percentile. And these rates vary by ethnicity and the socioeconomic status. In this country, it's the highest in the Hispanics and non-Hispanics, Blacks. It has increased more than 3 times since the 70s. The current national rates between 2 to 19 is 19.2%. So 1 in 5 children is obese. When you break it down between the ages, 2 to 5 years, it's 12.7%. 6 to 11, it's 20%, and 12 to 19, it's 22%. So this data is actually pretty staggering. The causes of obesity are mostly high-calorie eating habits. Of course, you have other, rarer conditions like Prader-Willi and Down syndrome and all the genetic conditions. But by and large, it is because of eating habits, sedentary lifestyle, and sleep duration may be associated with obesity because of sleep and hormonal release, metabolic changes, and lifestyle. So again, just delving a little bit more into the literature, what is the evidence saying about sleep duration and obesity? So there have been a lot of studies, cross-sectional, to looking at the relationship between duration of sleep and obesity in children. However, because these were all cross-sectional studies, in other words, they just took all these measurements in one point of time, they measured the child's BMI, they asked them, some papers actually did it with an actigraphy, so they have more objective data, but a lot of these is just questionnaire data, and said, yes, it certainly looks like children who reported less sleep time had higher BMIs, but because this was just cross-sectional, they couldn't establish a cause and effect relationship. That has to be done with longitudinal data. So we do have longitudinal data about this very topic. Most of these papers are from the West. And these, of course, every paper looked at a different age, different time of follow-up, but they all said the same thing. They said, for this paper from 2007 had a sample of 785, and they looked at them in the third grade when they were 9 to 10, and again when they were 11 to 12, 3 years later when they were in the sixth grade, and reported that short sleep duration in the third grade is associated with them being overweight in the sixth grade. These Agras et al. Reported at 3 to 5 years and initially, and measured them at 9.5 years, also said less sleep time in childhood is a risk for childhood overweight. Riley et al. Had the largest sample size, over 7,500 subjects, and sleep reported at 38 months reflected an obesity at 7 years. Again, they described short sleep duration at less than 10.5 hours at age 3, and they said those children are at risk for obesity. Again, that was a paper from the United Kingdom. Tavares et al., 915 subjects, sleep reported at 6 months. They had much more frequent follow-ups, 1 year, 2 years. They measured BMI Z-scores and said that short sleep duration less than 12 hours a day during infancy is associated with a high BMI Z-score at 3 years. So all these papers are trying to say that if you have short sleep early on in life, you're going to go on to being an obese older child. So basically, sleep deprivation, the conclusion is associated with weight gain and development of obesity in children. When they've tried experimental sleep deprivation, they found that it leads to weight gain, increased food intake, which is sort of the main mechanism for weight gain in these instances. Not only is there increased snacking, the number of meals eaten per day is also increased. And it turns out that the child prefers high-calorie dense food for a snack.
Dr. Maya, I don't mind to interrupt you in this for a few questions on this topic.
Okay.
So there's a little bit of interaction over here as well. So I wanted to ask you was when we spoke about this duration of sleep correlation to sleep to obesity, right? When we take pediatric clinics, especially with obese kids, most commonly the parents would be more like this is an obese child who's just sleeping all the time, or that he's actually sleeping more than what he should be doing and doing less physical activity. So that's a little contradictory to the way we're talking about the pathophysiology of obesity here, because we do see a lot of these obese kids in our clinics end up being quite lazy and sleeping longer. So how do we correlate that to why the obesity and the sleep issues are becoming a cycle here?
Well, I think that's a very good question and a very common problem. So I think this usually, I mean, that's the way the obesity clinics also do it. So you have to, work with the child. And first of all, I'm going to come to that in a little bit, but you have to rule out that there is actually no, sleep disorder that's causing this, Once you've ruled that out, however you do that, and then you discover that really this is a more of a behavioral thing. It's going to take a lot of intervention, not just by, controlling the nutrition. You have to, get the family to buy into, getting this kid enough physical exercise. And I know in a lot of times that is very hard to do because, kids have a lot of stuff to do, whether it's sports related, whether it's academics. We really don't have the time to expend on doing things like, following sort of an exercise plan, for example.
A proper routine itself. Many of them don't have
A proper routine. And also what we find is really important is this has to be a family affair. You can't have just one kid eating different kinds of food. And often that's a problem because the parent will say, how am I going to not let my other kid eat, something that may be a little bit more calorie dense than, you know, than what this obese patient should be eating. So it takes a lot of convincing, cajoling, and sort of hand-holding before this thing actually happens.
And one of the hormones that you spoke about was growth hormone. We spoke about how growth hormone plays a very important role in the pediatric age group. I think many people will be very confused as to, does that also play a role in adults? So we spoke about how growth hormone and cortisol varies. We all know that is before 6 years, 7 years, fine. But what happens after that? Does this growth hormone change in the hormone continue later in life? And even
yes.
do we as adults also secrete growth hormone as we?
Yes, we do. We do. It's not, the peak level is not as much as it is in children, but we also need growth hormone for just cellular, structure and well-being.
Yeah.
So growth hormone doesn't just disappear once we're done with our growth. We also need it for our muscle, our bones, every cell in our body also needs growth hormones. It's one of those.
And a lot of the metabolic functions as well. So
yes, exactly.
Growth hormone is also lipid metabolism, where we see
exactly.
that hormone breaks down fat. So I was wondering whether that also, because most people don't, we spoke about always leptin and ghrelin, and we forget to mention whether growth hormone also is playing a role in lipid metabolism and bringing down obesity when we sleep better. So I thought that also could be one of the ways.
It's maybe playing a role. It's a very complex relationship. Growth hormone is not one of the major players, definitely, for that. But I think, like you brought up, it's definitely not something that we should not be paying attention to in older children and in adults. It's definitely still pretty relevant. It is still secreted during slow wave sleep. So that part doesn't change, but you don't have those peaks like you do in childhood.
So we do tell them that there is function of growth hormone as well during sleep in the older age group as well.
Absolutely.
And I want to ask you about dyslipidemia. When we speak about obesity, dyslipidemia, sleep, OSA, for example, there's a huge trend of saying that all of these are inflammatory conditions now, right? So a lot of us also believe that obesity is inflammation itself, like over a period of time, is inflammation. So is all the sleep deprivation causing inflammation and therefore you're seeing obesity? Is that also a possibility?
It is possible. So like you mentioned, obesity per se is what they are considering an anti-inflammatory condition. And we also know that conditions, like you mentioned, of sleep disordered breathing gives rise to inflammation. So again, which one came first? So we also have very, very nicely done studies that say if you treat, at least in children, you treat OSA with, doing a TNA, or you even with CPAP use, things like IL-6, IL-1 beta, all those markers actually come down. So you know that the inflammatory conditions are definitely being treated by intervention. So, and then also we see that after bariatric surgery, all the inflammatory markers definitely drop in amount. So again, it's sort of a cycle, which one came first, you don't know. But it's all that you can only find out with longitudinal studies. Again, with cross-sectional studies, it's very hard to say cause and relationship. But these things are usually sort of either multifactorial and, in a loop, basically.
So in a sleep deprived child, suppose we have a sleep disorder and obesity, for example, I think that's one of the questions asked. If is there any role of measuring this hormone? You spoke about how ghrelin has a role. So is there a role of measuring ghrelin or insulin-like growth factors in these children to say, listen, it is the obesity, which is because of sleep deprivation, therefore it is elevated, or is there any role of doing that?
No, we don't usually do that. And in fact, those are not usually commercially available. And keep in mind that is very dependent on the time of day that these hormones are actually measured. So it's not done on any routine basis at all. Some people, at least in studies, have measured just things like ESR and CRP, sort of very, the broader inflammatory markers to see if there's any change. There has definitely been change. And again, most of this literature comes after a huge intervention like bariatric surgery.
Sure. You
So
spoke a
there's
lot
definitely
about
a drop.
drop.
I'm
Yeah.
sorry?
Yeah, please go ahead. Sorry.
So there's not like a role for these hormone measurements in tracking things, for example.
Right.
We don't do serial measurements of this.
We spoke a lot also about digital exposure. I think we went into digital exposure, obesity. Now, COVID times, what we noticed is obviously across India, there was a huge surge of obesity in pediatrics, especially during COVID times when they were locked down. So there were two factors playing there. One was they were having increased digital exposure and they were getting obese, right?
Yeah.
So do you think they were sleeping less? So why were we talking about digital exposure so much? I think there was a little confusion as to why we're focusing so much on digital exposure and sleep here. Are they all interrelated or what?
Yeah. Because so basically what's happening is and I think this is sort of a common thing that we have all seen, that the kid is sort of addicted, for lack of a better word, to whatever the electronic device is. And that is actually cutting into their sleep time considerably. So it's not only cutting into, so I actually, in a couple of more slides, I have something else that I wanted to talk about. But this has been a well-known, it's now unfortunately becoming well-established phenomenon that kids are on their phones a bit too much. They're also worried about the content that they're looking at, because that also is playing into, anxiety, depression, at least in this country, and I think it is over there as well. So it's affecting children's sleep, not just by the sort of insufficient sleep because they're spending less time sleeping. It's also the content that's sort of causing all other problems for them.
Oh, sure. Please go ahead with your talk. There are a few questions I'll ask towards the end as well. Thank you.
So this paper actually is from the Indian Journal of Medical Research in 2016, and this was a systematic review of trends of over childhood obesity and overweight between 1981 and 2013. So there were 52 studies from 16 states, age groups from 1 to 18. They used a variety of growth charts to describe or to monitor obesity. This is the International Obesity Task Force Scale, which is, I guess, what you guys use most commonly. At least that's what the paper said. They also use the WHO, CDC, and CDC Agarwal growth charts. What they found in this paper was the combined rates were higher from the north part of the country compared to the south. And of course, like everywhere else in the world, the prevalence had increased from 16.3 between 2001 and 2005 to 19.3 in 2010. So this paper actually, this paper was from 1991. So we've known from early on, that sleep deprivation definitely affects all sorts of things. So this particular paper, they used 8 healthy males and subjected them to different times of sleep. So as you can see in the columns, this one was 4 hours in bed, 8 hours, and 12 hours in bed. And they measured different hormonal levels. And what they found was leptin. Remember, this is the satiety hormone. That was lowest when you had the least amount of sleep. So notice that this peak is much lower than the others. What happened to cortisol? Evening cortisol was the highest when you slept the least. So sleep debt increases your cortisol hormones. And cortisol is sort of an alerting hormone. It doesn't let you sleep. It does it has a lot of metabolic functions. So it has widespread effects. What happens to growth hormone? There's still a peak. So this is clock time basically. This dark line is when the sleep time. So again, there is a peak during slow wave sleep, the early part of the night, but it's not nearly as high as when sleep is extended. What is HOMA? So HOMA is a measure of fasting blood sugar and insulin levels. So it is really what they use for measuring insulin sensitivity. That is high when there is sleep deprivation. So the least amount of sleep gives you a high HOMA, which equates to insulin resistance. So again, a problem. So I'm sure you all sort of experience this as well. So when you talk to children about, not being exposed to their electronics close to bedtime, they all say, oh, no, don't worry about it. I have blue light filters. So basically this blue light, which is the melatonin blocking wavelength, is emitted from a majority of devices that people use, including fluorescent lighting, LED lights, smartphones, TVs, computer screens, tablets, e-readers, as well as video game consoles. So this is basically when they tell you, so these blue light blockers or filters that they all use, it actually prevents the light of this wavelength. This blue light is a shorter wavelength and has high frequency. And these glasses that they wear prevent it from reaching the eye. But this study from Harvard actually looked at it and discovered that this monochromatic blue light of this wavelength caused twice the amount of melatonin suppression compared to wavelength of a higher light of a higher wavelength. So, and also these glasses that people were wearing and thinking that it works really well, only 10% of that was either reflected and only 35% was actually getting absorbed. So there is still a lot of blue light that's going through even these filters. And additionally, this paper also said that duration matters. Obviously, you're exposed to this for a longer time, your melatonin is going to be suppressed even more. So another big debate and perfect for a pro-con debate is exercise and sleep. How does exercise affect sleep? So in the pro group, Nixon et al. From New Zealand in 2009 recruited 871 children, and they were able to follow 591 of them at the 7-year follow-up. Sleep was measured by actigraphy. Additionally, for exercise, they measured something called a metabolic equivalent task. And what it is that it's the energy expenditure and calorie requirement at both rest and various levels of activity. What did they find? They found that higher mean daytime activity counts were associated with a decrease in sleep latency. So, and that was equivalent to 21.2 minutes per 102 movement counts per minute, which was a significant relationship. And the time spent in sedentary activity was associated with an increase in sleep latency. So the bottom line for this is the more active you are, the better your sleep latency. Your sleep latency is less. So exercise is good for sleep. What did the con people say? They said, no exercising close to bedtime because strenuous exercises elevates your body temperature. And we know that the body has to cool, the core body temperature has to decrease in order for sleep onset. Additionally, aerobic activity releases endorphins in the brain. We know those are alerting substances, does not let you sleep. And it can also increase sleep latency onset. So then they came down, this debate said, okay, sleep is not just dependent on a few factors, there are other factors involved. So whatever works for the patient, do that. They said, if they find that exercise is actually delaying sleep, then don't do it. If it doesn't bother you, do it. Because on the one hand, you're also promoting exercise. So they couldn't come down too strongly on that. So good sleep hygiene recommendations are to create a consistent bedtime routine, implement screen time curfew, set limits, avoid caffeine for about 6 hours before bedtime, large meals about 3 hours before bedtime, and strenuous exercise 1 hour before bedtime. These are the recommendations of both the American Academy of Pediatrics and the National Sleep Foundation. So this is sort of a nice sort of cartoon, I guess, of how you can soothe babies, what you can do for sleep kids at different ages. Babies, you have to, this is the behavioral insomnia sort of starting up, soothing your baby without picking them up, leave the room quietly when they're settled. For an older child, give your toddler control over little parts like picking out PJs or whatever the sleep routine might be. In adolescence, designate a space outside the bedroom for homework, play, or electronic device usage. So in other words, do not let them take it into their bedrooms. And for older kids and parents, actually, this is to set a good example of healthy sleep routines, because that's the only way that you can encourage a teen to follow suit. And this is, I hear this almost every time in a sleep clinic, where the child calls out the parent and says, oh, you do the same thing. And interestingly, when I read sleep studies, there is a video, right? So I can see in the video that the child is trying to sleep or might have already slept. And the mother, it's usually the mother, is in the bed with the phone. So, clearly examples are not being set. So in conclusion, I want you to take away that sleep is affected by many factors, both intrinsic and extrinsic. We should start talking about sleep in terms of sleep health, like we do for heart health, and other kinds of health. Should not be just talked about as like a disorder. Short sleep duration is associated with disturbances in hormonal and metabolic variables. Sleep promoting is to be included when addressing weight management, and medical causes of sleep disruption are to be ruled out before addressing the non-medical causes. And that's all I have.
Thank you, Dr. Maya. That covered a lot of the important points that we were looking for. I think it was covered a lot about obesity, about digital exposure. We have a few questions, so let's go through the questions before we think. Can you stop slide sharing?
Oh, yeah.
Just two questions which we have. One was with regards to, I wanted to ask you about the cardiovascular effects. I think we did not cover cardiovascular effects. Whenever we talk about adult studies on importance of sleep, all of them focuses on cardiovascular effects. Does that mean that there are no cardiovascular effects in children?
Very good question. So I didn't put that in because there is not such a strong relationship as of yet, is what people are saying, to the as a cardiovascular risk. However, they do caution saying, the other things that we know are risk factors in children, like the metabolic syndrome, in adults, like metabolic syndrome, hypertension, etc. We are already seeing that in children. We just don't see, them having heart attacks in their 20s, but they are on the same trajectory. So they are cautioning that, we definitely send patients for cardiac evaluation before bariatric surgery. So that's part of the routine workup. But we have not seen such extensive, atherosclerotic plaques, for example, in children. But again, everyone is well aware that other risk factors are already being seen in children. So that is something that may be coming down the pipe.
Sure. Second question which was raised with regards to depression and sleep issues. Does depression cause sleep issues, or do sleep issues cause depression? So how is
again, very good question. But what longitudinal data has actually told us is that sleep problems come first before the depression starts. So, and this relationship is much more strongly held in cases of insomnia, though. So people always think that, depressed patients, or whatever the psychiatric problem might be, is going to lead to insomnia, but it's actually the insomnia and the sleep disorder thing that comes first. So they always say that, if insomnia starts getting worse, that the depression is going to also follow suit. It's going to get worse. So it's usually the sleep-related problem that comes first, even though it's so closely related.
Yeah, because we think we see it a lot in our adolescents today, that depression itself is so all of it is interrelated. Like you said, digital exposure, sleep deprivation, and depression are becoming a significant cycle there. So what are do you suggest that to overcome depression, that the sleep has to also be addressed during depression counseling?
Yeah, I mean, I don't, see patients for depression per se, but what I do in my sleep clinic is I give them a depression and anxiety screening questionnaire. So, and that just asks, like one has, it's GAD-7, which is what we call, use for the anxiety. It has 7 questions. And for depression, it's called PHQ-9. It has 9 questions, Pediatric Health Questionnaire. And then if they score high on that, obviously, then that has to be addressed. But very often I find that patients who have a lot of sleep-related problems score high on those 2 questionnaires. And then obviously we have to direct them to, the psychiatrist or the counselor or somebody like that, because these have to be addressed hand in hand.
Sure. So right now we're doing a lot of talks in schools with regards to how children should sleep well during exam season, especially. Now exams are going on across India. And one of the focus areas I focus on is why children should sleep well before their exam. Can you tell me why it should be, or what is the function of sleep on scholastic performance?
So sleep, deprivation, and this again, literature is mostly on, from the sleep disordered breathing literature, where they found that kids who snore and have interrupted sleep, their school performance is less. But that can be translated into, poor sleep quality, including insufficient sleep. We all know that how if you don't sleep enough, your recall, you don't have enough REM sleep. And REM sleep is paramount for memory recall. So all the things you've studied the previous night, people think, oh, I'm going to just stay awake all night mugging, is going to get me through the exam really well. Unfortunately, it doesn't work because your memory consolidation, which happens in REM sleep, is being affected. So it's always a good idea for not, just for you to be also calm and collected so you can take your test in a proper way, for you to get sufficient sleep the night before.
Sure. So which is another point where we focus on both attention and memory. So what we counsel a lot of the children is on how short-term memory gets consolidated to become long-term memory during sleep. We say that whatever you just learned, so there is a high role that this short-term memory, what you just learned, becomes long-term memory because of sleep. So if you don't sleep, it's not going to become long-term memory as well.
Yeah, and exactly. And that is especially important in REM sleep. That's when it all happens.
And also a lot of role about how, the space for memory itself, whether you get enough more space, like a hippocampus gets more space for learning new things, like you said, also by sleeping. So it clears up and creates the memories as well. So I think one of the important things we also would focus on importance of sleep, why it's essential, is probably memory and attention as well. And attention deficit also can happen. One important area which a lot of us focus on now is ADHD. Again, it's a good thing saying that is sleep deprivation causing higher ADHD, or is ADHD itself causing sleep deprivation? But I think this is a question raised many times, that poor sleep does cause attention deficit. So is ADHD levels rising because of sleep deprivation?
I don't know if we can say that, because ADHD is sort of a multifactorial thing. It's got genetics, it's environmental, it's all sorts of reasons why ADHD prevalence seems to be going up. But what we know for sure is there is a lot of sleep problems in patients with ADHD.
Right.
Insomnia is huge. They can also have, things like periodic leg movements, movement disorders. They can also have restless legs. Sleep disordered breathing. So they have all kinds of other issues that could lead to, sleep.
It may not just problems. Be the primary cause as well.
Yeah, I don't know if that's such a clear-cut relationship, but it's definitely associated.
And one of the things which a lot of kids tell me, this is something which we didn't talk about, is that they oversleep on the weekends anyway. So I have covered my sleep debt. So if my sleep debt is anyway getting covered, then why would the functions in my body get affected? Because I am getting my sleep debt anyway.
Okay, so this is what they call social insomnia. So they, they sleep an extra 2 hours or something on the weekends. So to that, I think we should tell them that, your circadian rhythm doesn't just spring back into action the next day because you're sleeping longer. It takes a while to adjust. So with this, relative sleep deprivation during the week and extension on weekends is really kind of messing up your circadian rhythm. And keep in mind that you also have these peripheral circadian rhythms that have to also keep up with, your glucose levels in the body, all these other hormonal levels in the body. So it is not such a good idea to
not just the duration, it is also the rhythmicity and the regularity of sleep
exactly
matters as well. One last question, which I think is with respect to melatonin. So if we have sleep deprivation and all these are there, why not just give melatonin, sleep well? Like a lot of ads, and I was shocked that even in India now, I know it's common in the US, where in India now a lot of ads talking about sleep supplements, right? And parents come to me saying, see, I see sleep supplements along with multivitamins. Why can't we just give it to our kid? They will also sleep well. Everything is going to be well. So what is your take on that?
So what is the reason why they need melatonin, right? Is that because they are actually staying up and not sleeping? And the parent says, no, I want the kid to sleep at a certain time. Here's some melatonin. Just take it and go to sleep. So, there are conditions such as ADHD where we know that the melatonin pathways are affected. So in those kinds of patients, definitely melatonin is sort of a treatment. But in an otherwise normal child, say, oh, you know what, just don't worry about, staying up or whatever it is, here's some melatonin. I think we should emphasize to the parent that sleep is sort of a lifestyle thing to do, not just, you have to get sleep trained, unfortunately, even at an older age, to be able to say, okay, now it's my bedtime, now it's my wake up time. And I sort of emphasize to them that sleep is sleep for health, and it doesn't need any sleep aids, including melatonin, in order to be able to do that. Our body is producing enough melatonin to enable you to fall asleep, provided the rest of the environment is good.
Right. Just like
and the other, I'm sorry, Dr. Bharat.
Like
the other thing about melatonin is it's not very well regulated. You never know how much melatonin actually is in that supplement, whatever preparation you take.
Mm-hmm. Right. Just like how we say even multivitamins are not routinely recommended for everybody, right? So adjust your diet according to that. So melatonin is not routinely recommended as well.
No, not at all.
Yeah. So I think, so is there any conditions where you use? I think some of them have asked, is there, which are the conditions where you would recommend melatonin there in pediatric?
In patients who have ADHD, is definite. It definitely works for those, because we know that those levels are not appropriate. And other, there are a lot of genetic conditions where they have, midbrain anomalies and things like that, where the pineal gland area is definitely affected. Those patients, they are definitely.
So those are specific places where we do.
Yeah. So kids who are not normal, they definitely have circadian rhythm abnormalities, and those patients should be given that.
Right. Finally, final question is, what are the final recommendations that you would give pediatricians now to counsel parents on? I know you spoke about sleep hygiene, but a lot of parents are worried about winding down the kid, getting them to sleep well. So what are the basic tips that you would give for getting a child to wind down before sleep and relax before sleep time? Few tips on that.
So the tips will be like really what we covered already. Say, don't eat heavy meals like close to bedtime, which sometimes I know we kind of say, oh, let's just eat this before going to sleep. And you can certainly have a light snack, but not something terribly heavy. Electronics, cut down the amount of ambient light. Sometimes they need, white noise, which could be in the form of, just some music that they want to listen to, or, I don't know. Do you have white noise machines there?
Yeah, we do. Now with Alexa, has white noise around here.
Okay, do some white noise and just follow some very basic steps. But the key thing is consistency. Everyone has to do a buy-in, because if you have, and I know it could be maybe a bit more of a problem over there with multi-generational families, everyone has to say, okay, it's wind down time for the kid,
Especially there is father comes in late, wants to play.
Yeah, exactly. So it's really sort of a lifestyle sort of adjustment for the whole family.
Thank you, Dr. Maya. I think this was a very educational talk. I'm sure everybody enjoyed it a lot. Questions were quite a lot. And I hope you enjoyed talking to us back in India.
Yes, I did. Thank you so much.
Thank you. Hope to see you soon again in India.
Okay.
Thank
Bye,
you.
everyone.
Bye.